Good evening, everybody. I'll begin just by quickly introducing Dan Pomerantz, who's the facilitator for this session tonight. Dan is the governor for the Hudson Valley region of New York ACP and is our chapter president. It's also my privilege to introduce Jennifer Sweeney, who will present our program this evening. Jennifer has an extensive and successful background in public policy, health policy, patient advocacy, and patient engagement. She's a native of the Hudson Valley and a graduate of Union College in Schenectady, New York, which is also my alma mater. And she earned her master's degree at Georgetown University in Washington. I've had the pleasure of knowing Jen and first had an opportunity to work with her back in the days of the Comprehensive Primary Care Initiative, CPCI, beginning more than 10 years ago. At that time, she was in a leadership role at the National Partnership for Women and Families and was a tremendous help to our practice as we were establishing patient and family advisory councils. She's a co-founder of X4 Health, which is a woman-owned small business dedicated to advancing the quadruple aim in healthcare. And she's also a co-founder of The Third Conversation, a project dedicated to creating synergies between patients and clinicians with a goal of engineering humanity back into healthcare. So take it away, Jen.
Thank you so much, Lou, and thanks so much to all of you for asking me to participate tonight. I'm really excited to be here to talk about two of my favorite things, partnerships with patients and systems change. And as Lou said, I am originally from the Hudson Valley, Cornwall-on-Hudson, which is where I grew up and loved every minute of it, and then went to Union College in Schenectady. So this feels like a reunion for me. So again, thank you for inviting me. And I'm also really happy to be here with you, Lou, and also with Dan. So as Lou mentioned, I did get to know him during the CPCI days, but we've also been working together with ACP for a number of years now. We were on the well-being and professional fulfillment. I think it was a committee at the time trying to determine if we wanted to create a committee, in which we have, and Dan and I sit on that now. And I think I would just like to say thank you to you, Lou, and to you, Dan, for your interest in partnering with patients, but also for your championship of this concept and really, devoting the time this evening to talking about this issue. So thank you for that. So here's a rough outline of my plan for our time together. So I was going to share three things. One, a range of ways to partner with patients for system change. Two, a couple of stories about partnering with patients for systems change that give me hope and may give you inspiration, at least I hope so. I'll also share some best practices as well as things I would avoid altogether when it comes to partnering with patients. My overall goal tonight in presenting is to share actionable strategies that you all can take and apply in your own practices or systems. And I'd like this to be a conversation with all of you. So I'll probably pause a couple of times in the conversation or in my presentation to see if you all would like to join in, and then we've left time at the end for discussion. So before I dive in, I want to share, I think, three biases that I really think I should be upfront about because they shape my overall philosophy when it comes to partnership. And I just want to make sure that I'm clear about those. So number one, I believe patients and clinicians have the most to lose and the most to gain when it comes to our current system. Number two, I believe patients and clinicians are interacting in a larger system that pits us against each other. It hasn't always been that way, but it is today, and it's having a negative impact on all of us. And finally, I believe with my whole being that if patients and clinicians were to come together en masse, we could create unprecedented shifts in the system that would benefit us both. So that's my disclaimer, and I will dive in. So when I think about partnering with patients, I think of it as a continuum. So I'm going to share a range of ways to partner with patients for systems change, everything from short-term to longer-term, and from easy lifts to more intensive efforts. So at one end of this continuum would be asking a small group of patients to provide you with feedback on issues in your practice. And it could be anything from your waiting room or your phone tree, for example. These are a very low risk, low lift way to partner with patients. And in my experience, it's better than just assuming or guessing, how patients feel about important aspects of your practice. So what I have found is that if you ask your practice manager or someone from your patient experience team, if you have that, to invite 6 to 8 patients for lunch and then tapping into their wisdom, it can work really, really well. Alternatively, you could also share with a select group of patients the feedback you've gotten in patient experience surveys and ask them to weigh in on the results. And then, maybe even share ways to improve the domains where the feedback could use some improvement. As we all know, patient experience surveys don't tell the whole story. And in my experience, direct feedback from patients themselves is so much more granular and I think therefore more actionable. So those are just 2 examples. And, in these examples that I just described, you're only committing to a one-time engagement. But even in that, small engagement, what I have found is that patients offer incredibly insightful and useful feedback, even if you're just meeting with them for 1 hour. And, I'm using these examples of the waiting room or the phone tree. These are not, I think, like the most impactful things in a practice, but they do play a part in patients' experiences. And I think that can be a great starting point if you haven't partnered with patients and families in the past. So I'll share a story here that I think exemplifies what I'm talking about. So one day I was doing a walkabout with some patients actually in a practice in New York, and I asked them to share some thoughts about the waiting room. I think there was about 6 patients, and they unanimously declared the waiting room unwelcoming because the entry wall had at least 5 signs hanging up. And here's the kinds of things the sign said: silence your cell phones, no guns allowed, keep your voices down, don't approach the desk unless called. Now, the patients didn't say that these signs should be taken down. They didn't even, suggest that in any way, shape, or form, but they felt like they should be balanced with signs and messages that were welcoming and that made it clear that they were in a space for healing and for healthcare. The patient said, without that balance, it was like they were being yelled at right when they walked in the door. And it also felt like they could have been at the grocery store, at the bank, with these sort of just signs everywhere, not necessarily a place where they were going to have a trusting relationship focused on their health. So this particular story gives me hope because the patients shared their feedback in a really gentle way. They were not, accusatory. They weren't angry. They just said, listen, when we walk in, we'd like to feel welcomed. We want to feel like we're entering a place where we are going to get, care and that we'll be in this trusting relationship. And on the flip side, the practice folks that I was working with at the time, they weren't defensive at all about this feedback. In fact, once they looked at the entrance through the patient's eyes, they all realized they needed to make some important changes, and they did. So one thing I'll say about these short time-limited approaches and the examples I just gave is that, these are really coming from my work that I did for many years and still do to help systems and practices engage patients and families and become more patient-family centered, the work that Lou talked about. That's not, however, to say that you couldn't talk with patients about systems changes that could benefit clinicians and other members of the practice versus solely focusing on patients' needs. And I'll go into that in more detail later in my remarks, but a lot of my examples early in my remarks tonight are going to focus on patients' needs because that really is a lot of the work that I did for many years. Okay, so back to our continuum of partnership opportunities. So a second way to partner with patients in systems change is to include them as members of the team when you're tackling a specific project or doing a quality improvement, PDSA cycle of some kind. So this is a deeper engagement than just talking with a group of patients because you're going to be asking these patients to work directly alongside you as you examine processes in your practice or system and as you make changes. At the same time, this kind of engagement can be time limited. So you're not locked into partnership indefinitely. And, at least in my experience, ostensibly, you're doing this kind of quality improvement work already. So you're not adding additional burden to your team. You're just adding team members to that team. So I recommend this kind of partnership opportunity when you're trying to improve outcomes for a certain patient population. So let's say patients with diabetes or parents with kids who may be at risk for obesity. The patients you invite on the team can pull back the curtain and give you a bird's eye view into what's working within your system or practice for these kinds of patients as they manage a condition and what's not working. So I know you all know this very well. I'll just share some things that I've noticed over the last couple of years, which is that, our collective thinking about health has evolved greatly in recent years. I think there's a greater understanding now that we all need to be aware of social drivers that influence health and well-being and patients' behavior. So, whereas years ago, when my kids were little, 21 years ago, and I would take my kids to the pediatrician, the care team would advise me on ensuring my kids ate fruits and vegetables on a regular basis. I think now we understand that, many patients live in food deserts. Others are dealing with food insecurity. And I think I don't need to tell you all that, these are difficult issues to broach in a time-limited visit when you're already under pressure to accomplish so many things. So what you might want to consider is inviting a cross-section of patients in, folks who are dealing with diabetes or who potentially have kids, who are at risk for diabetes. Ask them to talk with your team about social drivers. It'll give you a really great way to understand the realities of the patients you're living with, or the realities your patients are living with. It'll also help you, not make recommendations for them in a vacuum. You'll have a better sense of what they're up against when they leave your practice. So my favorite story of this kind of engagement is from when I was working with a practice in Arkansas as a part of HHS's Comprehensive Primary Care Initiative, which is, again, how I met Lou. And the team was reviewing the support they provided to patients with a particular condition, and they had actually added 2 patients to the team. And they were sharing a 3-page document the practice gave to patients about community resources. And, the patient said, sorry, but this document is, and they use this word, quote unquote, useless. And again, they said it in a very gentle way. They were not, condemning anyone or being rude or anything, but they said, listen, this document is useless. We can't use it. Well, it turns out the document, did seem comprehensive. It was pretty long. It included a long list of community organizations that the patients could reach out to once they left the practice. But some of the organizations had shuttered their doors years before. A couple had changed phone numbers or web addresses and were completely unreachable. Other organizations on that list had stopped providing the kind of support the practice was hoping to refer the patients to. So, they picked up and said, oh, well, we don't do that anymore. Bye, click. Well, the practice team learned that this referral information was not useful because as part of the PDSA they were doing, they asked the 2 patients on the team to walk them through their experience. Everything from calling the front desk to make the appointment, to entering the clinic, to getting home and following up on the care team's instructions. They wanted to know, what was that experience like, soup to nuts? So this story gives me hope for 2 reasons. One, my work in Arkansas took place, I think, about 10 years ago. And even back then, I was really happy to see that this practice was recognizing that they couldn't meet all of their patients' needs, within the 4 walls of the practice. And things have gotten worse, as I hear from the clinicians I work with. And they had done a really great job of inventorying the assets within their community they could refer patients to. They just needed to put a process in place to review and update the resource periodically. And thankfully, they learned the importance of that by including 2 patients on their team. They've done that, since, and things are going well. I want to reiterate what I shared earlier, which is, again, this example that I just shared it's focused on patients' needs and, community resource and having access to them. But you could ask patients to provide feedback on other aspects of your practice that have implications on staffing or hours of operations that in the end could result in systems changes that could improve the work experience for the clinicians and the staff in your practice. So just want to make sure I say that. So I'll pause there actually, because I'm going to go further into the continuum, but are there any questions or comments or feedback before I dive into the next part of my presentation? One, some of these problems are out of our control. So one of the things that I do focus on in all of my work is the locus of control, because you have to have some wins along the way, particularly if you're starting out partnering with patients and families. You have to have some way to show that the work that you're doing with your team is impactful, and there's a return on investment, if you will. Although I would say that there's always a return on investment from hearing from your patients. That's just my bias. And I will touch on exactly what you mentioned about sort of looping back with folks when I go to the best practices part of my remarks. So with that, I think I will first thank you all for chiming in. I hope you'll do that as I pause in the next section. I think what I'll do now is talk about going further down the continuum. So, back to the continuum, I've now shared two particular ways that are sort of more, time limited and low risk and low effort. A third way to partner with patients for systems change is through patient and family advisory councils. And this is somewhat of a deeper engagement because you're creating an infrastructure, a council, and you're asking patients to devote their time at regular intervals for about a year. That's, in my experience, patient and family advisory councils tend to run about a year. You want to give people time to sort of do the work that we were just talking about. So when you stand up an advisory council, there is work to be done. You need to recruit patients. You need to have a slate of objectives you want to accomplish. The last thing you want to do is launch a patient family advisory council, have everyone come to the first meeting and go, hey, what should we talk about? Because that is a prescription for disaster. You want to have some specific things that you have in mind that you want to tackle. And then you want to ask the patients and families who are sitting around the council to chime in and add to that list. But you don't want to have a meeting where you start from scratch. You also want to ensure that you have someone in your practice or system that's responsible for the council work. And all of that requires staffing and time, and in some cases, money. With all of that said, patient and family advisory councils have really evolved quite a bit in the last 5 years, and even more so in the last 2 years since the pandemic. So in the early days when I was doing this work, patient and family advisory councils, they met in person, which meant you needed to reserve a room, you needed to have food available typically. Some councils provided parking vouchers. Others, I worked with a council in Minnesota for years, and they would have patients, this was a very rural part of Minnesota, they would have patients drive 2 hours each way to go to a council meeting. So they would reimburse for gas. I've worked in the Bronx and in Harlem, and some of the patients we worked with there, they needed childcare. There was no way they could come to a patient family advisory council and leave their kids, in the evening. So they would provide childcare in many different ways. And that is still the case with some councils. They're still operating that way. But these days, many other councils have moved online. It's amazing what has happened, as we all are seeing here with the Zoom meeting. Everybody's using Zoom. My parents are on Zoom. Everybody is on Zoom. So lots of these patient and family advisory councils are happening on Zoom as well, which has decreased the coordination that's needed. It's also decreased the budget in many cases that's needed because you don't have to pay for parking or childcare. It also means in many cases that these councils are more diverse. So it used to be when I first started doing these councils that most of the people sitting around the table were retired. They were older people. They could afford to take time out in the middle of the day and to show up in person for a meeting during a workday. Thankfully, I think with this move to the online format, councils today are more diverse at every level because people from all walks of life can log onto a Zoom during their lunch hour and participate in a meeting. So I have worked at this point, I think now, with hundreds of patient and family advisory councils over, again, about a decade in pretty much every state in the country. I'll share a couple of things that I've seen councils do, but really there is no limit to the ways in which you can engage patients and families in a council work. So developing new wayfinding and signage, that's actually been really important, particularly for hospitals. Communicating policies and procedures. Patients can be really insightful about how to say things in ways that don't seem, aggressive or like you're shutting down, the patients in any way. It's just they're really good at helping you word things in a policy and procedure manual, for example. They can help develop patient-facing education materials. Patients are great at that. They can also streamline patient throughput for office visits. I had a patient share really, vulnerably during one patient family advisory council meeting that they would come in for their checkup, for example, and the doctor would bring them back and they would have this long conversation about what was going on. And the entire time they were really hungry because they had been asked to fast. And they couldn't really always answer the questions because they were really hungry. They had became hangry, if you will. And this was really a surprise to the clinic. They were like, oh, well, we've always done it this way. And the patient was like, well, that's fine. There may be some patients who can go back and share, in an intelligent way what they're going through as a patient. But for me, like if I haven't eaten, it's really hard for me to do that. So maybe what you could do is start with drawing the blood at the beginning of the visit. Invite the patient to have, something to eat like a banana or a protein bar or something, and then continue the visit. So those are just some examples. So for me, I actually personally was a member of the Patient Family Advisory Council at my local hospital where I live here in Arlington County, Virginia. And I loved that work. So one of my favorite projects was a fact-finding mission that our PFAC did, Patient Family Advisory Council, to figure out why some patients weren't coming to outpatient surgery on time, prepared for their surgery, or with an understanding of how the process would unfold, while other patients did show up on time. They were ready and they were informed and they were happy with everything. So I remember at the time, as we were sort of embarking on this project, there was this temptation to assume that the differences among the patients were due solely to the patients themselves. Some people show up on time, some people don't. Some people read the materials, some people don't. Some people listen to the call, some people don't. That was a temptation. But, as a council, we all decided we wanted to dig deeper. And we embarked on this 2-month process that involved the following. So first, we interviewed patients who had undergone outpatient surgery in the last 2 months. We interviewed hospital staff, and then we interviewed a wide range of ambulatory staff who were in charge of conducting surgery prep calls with patients. Well, as it turned out, the calls that were being done by the ambulatory staff were very inconsistent. So some staff did a great job relaying information and answering questions, but others were doing the calls without a script and they left out really important information. And then there was a whole other group of ambulatory staff who were kind of squeezing in the calls at the end of the day and rushing through them and leaving out information. The common denominator, as we dug even more deeply, of the quote unquote bad calls was that they weren't anyone's, chief responsibility. And they were actually seen as an added burden to the staff who were doing them, not as an important component of ensuring quality patient care. Because they were talking to patients who, would then go off into outpatient surgery and they would see them maybe later, but maybe not. So it wasn't also just how the calls were being made, but the actual words that were used in those calls. So our council took a look at one of the scripts that were available, and immediately we knew right away that there was an issue because the language was a barrier, even for English speakers, even for someone like me who, has worked in healthcare for 20 years now. There's tons of healthcare jargon and acronyms and just, language that only insiders would understand. So we did 2 things. One, we made a list of the information patients told us they needed and wanted prior to surgery. Then we shared a version of that script with the team at an 8th grade reading level. So some of us had worked on health literacy issues, myself and another person. So we, did as good of a job as we could, but we also recommended that they work with a health literacy expert to create a script that the average person, someone without any healthcare background, could understand. And then we also encourage them to work with the ambulatory staff on site to help them see how important this role was and to help them carve out time during the day to make these calls, because these calls really have a huge impact on patients' preparation for outpatient surgery. Turned out it was a huge win. It made a huge difference to the outpatient surgery team, to patients' experiences, and to the ambulatory staff in general. So really happy about that. So the last thing I want to say about patient family advisory councils, and then I'll pause again, is I have in these remarks sort of painted patient family advisory councils as sort of at the end of that continuum. So a little bit more time intensive, a little bit more, deeper engagement, if you will. And that is because in my experience, that has been the case. Councils tend to be this infrastructure. They tend to be a part of a larger organization like a nursing home or a hospital or a large system. But if you are working in a small practice and you want to partner with your patients in a structured way, for a longer period of time, you can do that. And you don't have to make it a year-long commitment. You can say, listen, we have these specific goals and, we're going to work on them together. And this might take us 3 months. And then we're going to disband and we're going to thank you for your time. And, everything will be good. So I think typically we've tended to use patient and family advisory councils for larger groups and larger organizations, but that doesn't have to be the case. So I'll quickly share some best practices when it comes to these types of engagements. I'll open it up for questions and then I'm going to share or comments, and then I'll share one last example. So best practices. One, the first thing I will say is one is the loneliest number. So I can't tell you the number of practices that have said, we're just going to call like one person and we're going to bring them in and we're going to ask them some questions. And I highly advise against that. Every patient I have talked to is, even if they're going in as a group to a council meeting, they're intimidated. They're like, oh my gosh, they want to ask, my opinion. They want my feedback. So asking them to do that alone is something I would not recommend. I would say at a minimum, have 2 patients, in a conversation with you, but really you want to have, 3 or 4 at a minimum, because they will represent a range of patients in your practice. Number 2, it's really important to seek out feedback from as many patients in your practice as possible in terms of demographics. So you want to make sure you're hearing from patients depending on their race, their gender, their age, their income, their education, because as we know, we all, have different privileges. So you want to make sure you're talking to people who look like your practice, from all walks of life. Number 3, avoid window dressing. So, I think it's tempting to want to talk to the patients who are really happy with your practice, where everything's going really well, who give you, constructive feedback. You definitely should do that because we all deserve to get constructive feedback. I also think it's important to seek out, that person who sometimes isn't happy, has shared some feedback about things that haven't gone well. You want to know what's not working as much as you want to get that positive feedback. Number 4, always be clear about expectations up front. So for example, if you are asking patients to share feedback on your patient-facing materials, for example, but that you're also going to work with a communications firm and they're going to have the final say on those materials, you got to tell the patients that up front, because they're going to be curious about what impact their feedback, is making. So you want to say, listen, we're going to be working with you, but we're also going to be working with this communications firm. We're going to come to a place where we're incorporating as much of both of your feedback as possible. So be really upfront with those expectations. You can also be upfront about things like, listen, we're going to do our very best to take your feedback and to work with you to make changes, but we can't do everything, So if patients come to you and they say, listen, we want a swimming pool in the waiting room, that's not going to happen. Just tell them, we don't have the budget for that. People are people and they'll understand. And then finally, this is something that you touched on, Dr. Rubin, looping back with patients and telling them what you've done with their feedback, or telling them what the result has been of a process change or a policy change. So, the reason the example I shared with you of the outpatient surgery is so meaningful to me is not just because I invested the time and effort to be a part of that project, but because I learned that it made a difference. The outpatient team was happier, the patients were happier, the ambulatory staff was happier. That's why I do this work. I want to know that my input is making a difference. So make sure you loop back with folks and say, listen, we tried this and it didn't work, but we're going to try this. Or we tried this and it did work, and here's what happened. They want to know that information. So I'll pause there before I dive into the next part of the presentation. I'll just invite you all to open up with thoughts or comments or questions.
Jen, can you comment in the context of patient family advisory councils or any other group setting where patients might gather to, to have feedback solicited or provide feedback. Can you comment on privacy concerns? Some people are intrinsically storytellers, and they may go more deeply into their own, history, their own issues, family dynamics, God knows what, that may not be appropriate conversation for that sort of forum. So what expectations would be important to establish on the front end with respect to that? And how would you advise folks to deal with it if it hits the fan in some way?
Yeah, so that's a great question. So I'm actually dealing with this right now with one of the institutions I'm working with. We always share at the beginning of any work we do that it's really important to advise the council in general to keep everything confidential within the meetings. People can feel free to share whatever they want, but nothing should leave that room. So that's just a general expectation that we always make at the top of Patient Family Advisory Council. So here's my understanding. I'm not a HIPAA expert, although one of my colleagues is. My understanding is that the patients in a Patient Family Advisory Council are not part of the covered entity. So if they were to disclose confidential information that a patient shared, they would not be liable or going against HIPAA in any way, because again, they're not the covered entity, and the patient willingly shared the information. With that said, I don't think there's any downside to asking folks to sign a HIPAA waiver of some kind and saying, and again, encouraging at the top of every meeting, like, we are sharing personal information here, confidential information, all of that information should be kept confidential. I will also say, for the hospital that I participated in, the council, I actually had to do HIPAA training. They were, very, very clear that any volunteer, and there were actually, I had to do volunteer training and HIPAA training. And they, so I think it just depends on the organization and their policies, but at a minimum, you should be encouraging people to keep any information shared within the meetings confidential. And you can go as far as having people sign waivers to training, HIPAA training or volunteer training. So, we're closing on the end of the continuum. So I'm going to share about one final partnership example, which is a program called Third Conversation that I co-created 5 years ago with my colleagues at X4 Health and with a primary care clinician named Andrew Morris-Singer. So Third Conversation was directly inspired by the work I mentioned earlier that I had done for years with hospitals, practices, and systems to help them partner with patients and families. So I'm, very proud of that work, and that's why I spoke about it tonight. And I, to this day, believe that it's very important and can result in needed systems changes. And I use sort of system with a small s, if you will. But yeah, in my experience, that partnership work overwhelmingly only benefited patients, the end results, if you will. And it didn't get to those big S system changes that you're referring to, Anne. I'm not going to go into all of the reasons why the work I did focus mostly on patients. There are reasons for that. A lot of it had to do with the Affordable Care Act, and some of it was just inescapable. But basically 5 years into that partnership work, I began learning more and more about deteriorating clinician well-being. And I became concerned that clinicians' needs weren't being addressed. So my colleagues and I embarked on a 6-month effort in which we dove into the clinician well-being research, and we did a series of in-depth interviews with clinicians around the country to hear about their experiences. And during the course of that work, what we realized was that patients and clinicians were having conversations about the ways in which the system was letting them down, the ways in which the system was incredibly frustrating to them and disappointing, but that those conversations were happening in silos. Clinicians over here, patients over here. And it's actually, quite frankly, why I, having worked in healthcare at that point for 15 years, had almost no clue about what was going on with clinician well-being. I had been so focused on patients' needs and patients' outcomes. So we wondered, my colleagues and I, what would it look like if we facilitated a third conversation and brought together patients and clinicians to share their experiences and to connect deeply with one another? Could that sharing and those connections result in systemic changes that would benefit both patients and clinicians? And deal with a lot of things you said, prior authorization being one of them. So we created Third Conversation, which is a professionally facilitated experiential program that brings together patients and clinicians for about 2.5 hours to talk about, one, their best of patient-clinician interactions, two, the ideal healthcare system and what it would look like if the system prioritized relationships and humanity, and how patients and clinicians can show up differently for one another going forward in this insane dysfunctional system. So here's what we've seen happen in Third Conversation experiences all over the country for the last 4 years. So one, patients and clinicians realize they share many of the same hopes and dreams for the system and many of the same disappointments and frustrations. They realize that they sometimes make assumptions and conclusions about each other based on very short interactions within a system that is set up to pit us against each other. They undergo an awareness that the system has evolved in the last 30 years in ways that are problematic, not necessarily that we are problematic, that the system is. The patients learn what it is you all have to deal with every day to provide patient care. I will tell you, they do not know until they go through these Third Conversation experiences. I cannot tell you the number of times patients in our experience will say, I had no idea what you were up against. I didn't know that, health plans would only let you have a 15-minute office visit or a 7-minute office visit. I thought you just needed to rush out and go see someone else. And in these Third Conversation experiences, patients express deep appreciation for clinicians and the important work you all do. Clinicians, on the other hand, also, they tell us the experiences remind them why they went into healthcare in the first place. And they are so grateful to hear the appreciation from patients in these experiences. So I'm not going to go into, what Third Conversation is, because we're going to run out of time. I could talk about it forever. It is truly the thing I am most proud of in my entire career. But I want to share with you tonight a big realization and disappointment I had when it comes to Third Conversation, as well as some hope I have for the program. So I'm going to be really honest that when we were designing Third Conversation, my colleagues and I, we secretly hoped that it would lead to clinicians and patients coming together in large groups and marching on Washington. I live in Washington. I wanted to see patients and clinicians, demanding changes and going to
the people.
Right. And, and going to the front doors of regulators and health plans and saying, this is insane. We are no longer going to, accept this system, and recognize and sort of realizing that clinicians and patients, without us, the system doesn't exist. Well, I hate to break it to everyone, but none of that happened. None of it happened. And, in the beginning, I was surprised. I'm an advocate by nature. I've been advocating for stuff, since 3rd grade. But what we came to realize is a couple of things. So one, yes, we do have 2 stakeholders who are frustrated in not getting their needs met. But, there has been a lot of damage that has happened over the last 30 years. It's multifaceted. It's going to take a lot of time to unwind. Yes, it is possible, I think, that patients and clinicians can come together to create wide scale, change, but we need to do some of this healing first, the healing that happens in these Third Conversation experiences, because I think actually what we saw during the pandemic with, patients being really mad at clinicians about their stances on vaccinations, for example, patients spitting on clinicians for wanting and suggesting that they get vaccinated. I think there's a lot of healing that we need to do. And I think there's also a lot of awareness that we need to create to help clinicians and patients see how much they have in common. Because right now, most patients think clinicians just are rushing out of the door to go see another patient. They don't realize that, the administrative burden has gotten out of hand. They don't realize the number of patients that you need to see. So we have to, create that awareness. So that's sharing my disappointment and frustration. Let me tell you where I have some hope. So Over the course of the last year, my colleagues and I have been working with two institutional partners. One is the Grady Health System in Atlanta. The other is University of Mississippi Medical System. And what we've been doing is implementing these third conversation experiences at scale. Their goal going into this work was to have as many clinicians and patients experience third conversation as possible, with the goal being humanize healthcare, get back to basics, re-engineer relationships back into healthcare, and give people the sense that they matter, if you will. So we've been doing that now with these two systems, and we're seeing inklings that the same kinds of issues are coming up over and over. And the clinicians and patients are going, wait a minute, what if we worked on that together? Well, at the same time that has been happening, our team also created a program called Community Rocket, which we've been implementing in communities around or in a whole state of Oregon to solve complex problems. So what we're hoping to do in the future is to go into systems, have clinicians and patients and administrators. We also have a program for administrators that I haven't gone into. Have folks do third conversations, heal their relationships, get back to basics, remember what it's like to be humans together, and then implement these rocket programs where we'll focus on a particular issue that is a real pain point for clinicians and patients. Prior authorization is the first one I want, to focus on, because I've been hearing for years how frustrating it is, and it is for me as well as a patient, to deal with prior authorization. But I think we haven't been there yet. It's now, I feel like we're getting to a place where patients and clinicians see each other as potential partners for systems change, but we weren't there 5 years ago, or even honestly 3 years ago when I started this program. So I hate to end sort of on a down note in the sense that we weren't there then, but I do think we are potentially heading there now, and I'm looking forward to that. And I'm also looking forward to more conversation with all of you.